Hello to everybody. Once again, I would like to share an interesting viewpoint and presentation of this. The title is Nitrosogenesis of cutaneous melanoma, simultaneously development of primary cutaneous thick melanoma of the breast, thin melanoma and dysplastic bow of the back during parallel intake of bisoprolol, amlodipine and valsartan hydrochlorothiazide. Nitrosamine polycontamination in the multimedication is potential powerful skin cancer trigger. There is no conflict of interest and no financial disclosure, and this research did not receive any financial support. Polycontamination within the multimedication in polymorbid patients could be seen as one of the most serious obstacles at the moment for the current concept of skin cancer's pathogenesis in relation of the so-called metabolic reprogramming of the cancer cell. Recent clinical observations give strong indication that the number of potentially contaminated drugs taken could be seen as a determinant of the severity of the clinical picture and hence of the prognosis of patients with skin cancer and melanoma in particular. Concepts such as drugs-mediated nitrosogenesis and oncopharmacogenesis of skin cancer, for example, find their logical explanation precisely in the context of this contamination, which has been associated for decades with the possible generation of heterogeneous forms of cancer, but as consequence of, for example, dietary intake of nitrosamines, like stomach cancer, colon cancer, lymphomas, pancreas carcinoma, and so on. It is for this reason that we have initiated analysis, retrospective and prospective in their nature, of data in patients with cutaneous melanomas to establish or rule out a pathogenetic association between the intake of potentially nitrosamine-contaminated drugs and the subsequent development and progression of cutaneous melanoma. In the case presented, multiple cutaneous melanomas and dysplastic nevus developing simultaneously during the simultaneous intake of beta blockers, calcium channel blockers, sartans, and thiazide diuretics is presented. So that all four drugs that have been recently described and presented in the FDA lists are available in the patient's medication menu. Beta blockers, carcinogenic potency of 4, calcium channel blockers like amlodipine, potency of 5, valsartan between 1 or 2 carcinogenic potency, and thiazide of 4, so that we have a simultaneous intake not only of generic, real, pure substance, but additional a carcinogenic cocktail which might trigger phototoxicity, photocarcinogenicity, and genotoxicity, for example. We report a 63-year-old female patient who presented to the outpatient dermatology and dermatologic surgery clinic for a new onset progressively growing lesion on the left breast. In the detailed history and subsequently taken, the patient informed a pre-existing lesion of this area, which was no more than half a centimeter in size, homogeneous in color, regular in shape, and asymptomatic overall. The duration of the lesion, according to a rough retrospective calculation by the patient herself at the time of the anamnesis, was at least 30 years. The changes in the lesion occurred no more than 2 years ago or in 2021, when it progressively changed its shape, size, and color. During the dermatological examination, we found evidence of one pigmented lesion with asymmetrical shape, unclear differentiation from healthy tissue at some places, non-uniform coloration ranging from light brown to gray-black, diameter ranging from 1 to 4 cm in different directions, and a significant elevation in the centrally located area of the tumor. Dermatoscopic criteria showed a disturbed to completely absent melanocytic network in places, black to light brown areas, regressed white areas in places, and clinical and dermatoscopic criteria were entirely in favor of the diagnosis of cutaneous melanoma. In parallel, a second pigmented lesion was noted in the area of the right scapula, clinically suggestive for, and dermatoscopically, of course, of thin melanoma or melanoma in situ. A third pigmented lesion was also noted lateral thoracically on the left in the transition zone to the back, which was clinically and dermatoscopically suggestive of dysplastic nevus. Here you see the first lesion on the breast. It is clearly black diagnosis when a clinician take a look on this case. It is more than indicatively a melanoma or even a nevus-associated probably melanoma. And here we have a severe dysplastic nevi with some probably melanoma in situ and the dysplastic nevus on the back. The comorbidities were known to be ischemic heart disease, single vessel coronary artery disease, stable angina grade 3, hypertensive heart disease grade 2, both aortic and tricuspid insufficiency, and adventitial thrombosis of the descending aorta. The patient's concomitant medication included bisoprolol twice daily, 2.2 milligrams for 2 years, amlodipine 5 milligrams once daily for 10 years, valsartan hydrochlorothiazide once daily for 10 years, clonidine and riomidine. Preoperative screening included conducting CT with whole body contrast, as there was no evidence of dissemination of the process. Because of the evidence of dissection of the aortic arch and the descending aorta, urgent presentation to cardiac surgeon was recommended immediately after the first 2 excisions were performed under local anesthesia. Surgical treatment was performed according to the AJCC or European Journal of Cancer rules, and excision with surgical margin of no more than 0.3 to 0.5 cm in all directions in the forum elliptical excision was applied to the lesion localized in the breast area, and the defect was closed with single interrupted stitches. The histopathological finding was indicative for nodular malignant melanoma, stage 2B, Clark 4, Breslow 5.7 millimeter. Here you see the surgical excision, the tumor lesion, here with nice images. Fast, a great part of the breast was removed surgically, and of course here you see the postoperative result after that. The second lesion in the area of the right scapula was removed by one-step melanoma surgery with a surgical margin of safety of 1 cm in all directions in order to reduce the number of surgical excisions, and dermatoscopically this lesion was also indicative for melanoma in situ, so that we have taken the decision to make one-step surgical procedure. And of course there were clear resection lines, margins, Clark 2, Breslow 0.3, so that with this one surgical excision we have a better option for our patient. Here you see the one-step melanoma surgery which we perform since many years. It's a little bit different from the criteria used from the American Joint Committee of Cancer and European Journal of Cancer, but as you can see, one-time innovations could help in the determination and securing the patient's health. Here you see the postoperative outcome, and you see the last lesion. The patient doesn't want to remove it, and of course we have planned re-excision of the primary lesion of the breast by additional 1.7 cm in all direction and sentinel lymph node, but this was not the main problem of the patient because he has heart problems, and the primary securing the patient's health was in direction aorta operation. Why we want to present this case? Because in relation to our thesis, after we have published our works, we have additional strong international confirmation, starting from the proposition that the intake from 4 potentially nitrosamine contaminated medical products are taken simultaneously, and for a relatively short period of time. It should be not surprising to clinicians that this intake is associated with the generation of melanomas. The reason, therefore, is that nitrosamines are photocarcinogens, and genotoxic or and carcinogenic additionally. Monomedication with NDMA contaminated valsartan alone is regarded one of the newest French studies with 10% risk of developing melanomas. And it is a paper from Irene Mansouri and colleagues published in the Journal of American Heart Association. Additionally, there is another story. Monomedication with hydrochlorothiazide is also risky in terms of cutaneous melanoma risk without specifying whether nitrosamine contamination is present or not. And it is published in the Journal of American Academy of Dermatology 2023. Nobody informs here about the possible relation of phototoxicity to photocarcinogens like nitrosamines. So, discussion is also important. This is one of the papers which I want to discuss. Is from Sharma, Rastogi, and Goyal. A retrospective analysis of neoplasm in patients using angiotensin receptor blockers. It is from TED Talk 2024. Nitrosamines are known to have carcinogenic properties and are associated with increased risk of neoplasms. And they have a database with past 70,000 safety reports related to IRBs, to sartans, and among which more than 3,000 or 5% of the cases were associated with neoplasms. Among the IRBs, valsartan had the highest risk for the neoplasm development from all this. It is also a confirmation about the carcinogenicity and genotoxicity in some of the patients. In one of our previous presentations papers, we have also stated that the possible link between the genotoxicity and carcinogenicity of valsartan, and that it could be the reason for simultaneous development of prostate carcinoma and melanoma, or colon carcinoma and melanoma, and different types of other tumors. Antihypertensive medications and risk of melanoma and keratinocyte carcinoma at systematic review. Calcium antagonists and thiazide diuretics are associated, according to the most recent data, also with increased risk of developing melanomas. Of calcium channel blockers with about 10%, and thiazides about also 10%, and diuretics and thiazides are not only associated with melanoma development and progression, and probably different percentage of the associated risk with melanoma development depends on the level of nitroso contamination of the drugs taken by patients, and the problem is that these concentrations are not officially stated. Of course, an evidence was found for calcium channel and thiazides, and we present this Bulgarian evidence. The weak points of this meta-analysis remains again and its one-sidedness with respect to two main points: the lack of comprehensive assessment of data on additional factors in the context of concurrent simultaneous drug intake and relevant polycontamination, and the lack, of course, of information in each paper whether or not contaminants in the form of nitrosamines are actually present. In practice, nitrosamine contamination is not catalogued and described and remains known only to regulators. That is, if the study focused primarily on areas with reduced to absent contaminations at the expense of those with intense contamination, there is no way to account for this. Of course, photosensitizing antihypertensive medication and risk of skin cancer among postmenopausal women is showing some strong connections between sartan and diuretics intake and the risk of developing cutaneous melanoma. Antihypertensive angiotensin receptor blockers bear the risk of 82% developing melanomas, and diuretics 34%. And when we have this both intake, as in our patient, we do not have to ask ourselves, of course, why we have multiple melanomas in dysplastic nevi. Colleagues find association between intake of photosensitizing diuretics and sartans. For sartans, it is about 1.82, serious risk for cutaneous melanoma, and diuretics 1.34, so that serious risk for cutaneous melanoma. And we present the same patient, additionally calcium channel blockers intake. I want to Once again, remember one of the pivotal, most important studies coming from USA and published in Drug Safety 2017 by Beatrice Nardon and colleagues, old but very important American study. There, Beatrice has found that IRBs has been associated, we should see, with malignant melanoma risk from over 200, between 24 and 125%, independence if you have adjusted or non-adjusted odds ratio. Same or even stronger is this association with thiazides, 82% or probably 200%. Or 100% risk to develop malignant melanoma when you have monomedication with thiazides. And additionally to this, we have the same patients. Our patient has taken IRBs and thiazides, but same risk is for ACS. You have here 2.42 and 1.71 for ACS. What could be, was the question many years in myself, in my young team. What could be the reason which is, or the uniting factor between these three completely different classes of medication, which is linking the phototoxicity and photocarcinogenicity and the malignant, but not only malignant melanoma. You see here also basal cell carcinoma, squamous cell carcinoma development and progression. And FDA has given this answer to us. This is the nitroso contamination. Nitrosamines are photocarcinogens, mutagens, or only carcinogens. And the uniting factor in this study, these are the nitrosamines. New data from the registry of the Bulgarian Society for Dermatologic Surgery in Sofia, Bulgaria, about the intake of potentially contaminated drugs and the subsequent development of skin cancer and melanoma precursor lesions is showing a strong pathogenetic association. We have a huge amount of this data. So that we have published several case series where the strong pathogenetic connection between parallel intake of beta blockers, calcium channel blockers, sartans, and diuretics, and the subsequent development and progression of skin on keratinocyte cancer and melanoma has been presented, where the bridging link is the phototoxicity mediated by the probable availability of nitrosamines. We have another paper explaining the rising skin cancer incidence. This is showing the strong pathogenetic connection between the parallel intake again of beta blockers, calcium channel blockers this time, and sartans also, and the subsequent development and progression of skin cancer and melanoma precursor lesions also. The heterogeneous literature data are indicative of the development of melanomas after the intake of certain types of drugs like nitrosamines, as well as of an increase in the risk of advanced melanomas in the context of combined drug intake. This indirectly suggests the question, what is the cause? Could nitrosamines and NDSRIs be the unifying link? And here we came again of the metabolic reprogramming, which is a hallmark of cancer development and progression with activation of some RAS oncogenes, for example, and inactivation of the genome guardian like P53. However, this environmental factor is the UVB radiation and tobacco-specific nitrosamines. And the most reasonable questions should probably look like this. Should the concept of the metabolic reprogramming of a tumor cell of the skin, for instance, differ only due to the fact that carcinogens enter the body via controlled permanent continuous drug intake rather than via cigarette smoke or sporadic intake? And we are referring to one serious number of carcinogens and nitrosamines not yet fully studied. Some of them are genotoxic and at the same time phototoxic, as well as also found as a component of a standard medication, nitrosomorpholin, for example, but not only, many of them. Drug-related nitrosogenesis of skin cancer is the most modern and innovative concept in the medical literature that links the intake of nitrosamine-contaminated drugs procentually and the subsequent development of heterogeneous forms of skin cancer and melanoma in particular. The polycontamination of currently about 300 of the most globally distributed drugs with nitrosamines has been since 2023 officially declared in the FDA recommendations to manufacturers, and the number of effective preparations is growing every day. the answer remains unofficial till the present moment and is hiding between the officially partially disclosed data to the publicity from regulators, for example, like the FDA Bulletin or EMA or some other countries, and the hidden and not disclosed from the pharmaceutical companies to the patients and the clinicians. It is this metabolic reprogramming, nitrosamine, skin cancer, it seems to be more than a real craziness, but it is allowed craziness. Two very interesting facts could be not ignored, that certain nitrosamines such as NDMA could have a direct activating action towards some oncogenes like RAS oncogenes, and once metabolized their derivatives could also mutagenic such as methyldiazonium. This is the way showing us that monocontamination with a single nitrosamine could have probably polycarcinogenic effects in the human body given its metabolized and unmetabolized form. And this bicarcinogenic action is from interest. It might be. This is a paper stated for Michael White, and it is a very, very, very important one because this problem seems to be the tip of the iceberg. What is a worrying one? A worrying one, of course, is that some nitrosamines seems to be photocarcinogens. Some nitrosamines have mutagenic and carcinogenic action in humans. Some medications contain photocarcinogens like the nitrosomorpholin, and metabolic reprogramming by tobacco-specific nitrosamines in cancer is a very modern concept linking the UVB radiation and tobacco-specific nitrosamines as a hallmark for the cancer initiation processes. And we know that tobacco-specific nitrosamines are the reason after their metabolization that they could form DNA adducts leading to mutations in critical target genes in different organs, independent of what type of nitrosamines or NDSRIs has been taken or ingested or incorporated, including their leading to RAS oncogenes mutations and P53 tumor suppressor gene desactivation. Genotoxicity and phototoxicity of these nitrosamines has been already confirmed. Nitrosomorpholin, for example, is also a valuable respected member from the nitrosamine family. It is a photocarcinogen and genotoxic substance, which without activation in the liver is mutagenic, could be seen as potential environmental genotoxic factor when found on the human body. Once again, I'm showing a paper of a colleague of us, published in Archives of Pharmacy of Weinheim. Recently is showing that the most probable contamination affects the losartan, valsartan, metformin, and ranitidine taken by millions, but when not billions of patients. And here we can find the probable polycontamination on even one only tablet. This is a great problem because this paper is indicative for the following one. Polycontamination of a single drug with two nitrosamines is a reality and not a myth. Contamination of drugs with nitrosamines which are already proven as photocarcinogens like nitrosomorpholin is also a reality. And these nitrosamines are acting like bicarcinogens as stated. And there is no single also medical preparation on the drug market currently where we can be sure that it hasn't been affected due to the nitroso contamination. Nitrosamine checks mustn't have to stay the role in order to secure the patient's fates. Clinical pathological correlations seems to be from paramount importance because we have no official statement from the regulatory organs such as EMA and FDA about the real nitroso contamination. The polycontamination of the polymedication appears problematic with respect to the future development of heterogeneous type of cancers, inclusive multiple cutaneous melanomas. The monitoring of these possibly interrelated events could be seen at least as indicative of the care of the drug-related nitrosogenesis in skin cancers generation, at least as starting new hypothesis in vision. The careful analysis and follow-up of the intake of some new classes of potentially or actually nitrosamine contaminated products like AMLODIPINE, nebivolol, valsartan, and hydrochlorothiazide are able to lift the veil concerning photonitrosogenesis, carcinogenesis, and oncopharmacogenesis related to skin cancer and melanoma in particular. For dermatological science, as we have stated, some important dilemmas remain regarding nitroso contamination and especially pathogenetic relevance to the skin cancer, such as does certain nitrosamine or its metabolites have a triggering point to absorb photons and trigger phototoxicity, carcinogenicity? The answer is yes. Does it or its metabolites have the potential for systemic bioavailability and accumulate in skin to trigger skin cancer? The answer is of course yes. And these answers, the clinical answer, are coming directly from our clinical pathological observation, the timely dependent dose intervals, the continuous drug intake, and the continuous skin cancer development with new and new cancers each year. But it has been mediated due to the important knowledge that phototoxicity and differential hepatotoxicity as biological indicators of nitrosamine activity paper. It is a paper published more than 50 years ago, which is observation about 22 nitrosamines from standpoint of evaluating their phototoxic and hepatotoxic properties. And with respect to differentiation between carcinogenic and non-carcinogenic, phototoxicity appears to be a non-specific effect related to the photodecomposition of the nitroso group. From that point of view, the most questions about phototoxicity of nitrosamine has probably to vanish. We know that the photodecomposition of the nitrosamines is also well-known fact from 1964, and this paper, the confirmatory paper, is 1974. So that as a whole, we can state that photonitrosogenesis, drug-related skin cancer, remains no more a hidden truth and at the same time controllable process probably. Drug-related nitrosogenesis is essential part of oncopharmacogenesis or skin cancer's pathogenesis, and polycontaminated drug intake could be and is very often associated with the development and progression of multiple primary cutaneous melanomas. Early dermatologic surgery is a reasonable and adequate solution for newly arising drug-induced tumors, but it has generally no preventive effect. Skin cancer appears again. Tests currently used by regulatory authorities such as EMA and FDA to demonstrate carcinogenic or mutagenic activity should be viewed extremely critically as they have limited application in contrast to clinical pathological correlation. For example, demonstration of the carcinogenic or mutagenic potential based on static tests such as the Ames test in bacteria and CPCA test in rodents should not be seen as the most reasonable action of determining carcinogenic potential in humans in the context of monomedication. The processes of carcinogenesis often involve the simultaneous or stepwise action or activation of several carcinogens and or the parallel inactivation of a particular tumor suppressor gene following contact with nitrosamines in the context of the so-called metabolic reprogramming of the cancer cell. This is what eludes so-called tests, the dynamics of the processes leading to skin cancer development and progressions. These are dynamic processes which could not be determined, which could be not explained with these tests for me and my team. The regulators' efforts should be directed towards the complete elimination of nitrosamines and their derivatives in drugs. We have published this. I have published this paper in again of one PubMed Medline Index journal, and I think that our team has to be proud for it. I thank you once again for your attention, with a lot of hugs and greetings from the Bulgarian Society for Dermatologic Surgery from Sofia.